So what are the things, first of all, that an administrator needs to know? First of all, they need to recognize the importance of a school district addressing swallowing and feeding. They need to work with the specialists, the SLP, the OT, the PT, and the school nurses who know and understand the risks, they understand the disorders, and that they know what to do for children who have these issues. And then we need for our administrators to support us as we go through the process, because there's always going to be some disagreements and some questions from parents and staff. And sometimes we need that administration help. It's important because swallowing and feeding are complex disorders, and if left untreated at school can really result in harm to a child, such as choking, aspiration pneumonia, undernutrition, and dehydration. Our school board attorney said this relates to the duty of the school system to take reasonable steps to protect children from risk of injury. That is, to ensure a safe environment during meals and other activities occurring during the school day. School systems have an affirmative obligation to maintain a safe educational environment for the children they serve and to minimize the risk to those children by taking reasonable steps to prevent foreseeable harm. So when you employ SLPs and OTs who have training in swallowing and feeding disorders, they can see the harm that can happen to a child. So in order for a school district to prevent foreseeable harm, which of course is a legal term, the district needs to adopt a procedure and train the staff and get everyone going, making children safe. So it's necessary for the adoption of a team procedure, because we don't want any gaps in the treatment. We don't want any places where safety can be compromised. So a district-approved team procedure is really necessary when talking about a disorder such as swallowing and feeding. They're also absolutely necessary for hiring professional staff. So when you add this to the workload of SLPs and OTs who are already in the schools addressing many things, it may be necessary to add additional professional staff. And so this can't be done by an SLP or an OT or a nurse in the schools. This has to be done by a supervisor. Providing funds as well for swallow studies, equipment such as blenders and nook brushes and low-flow cups, helping to fund and organize professional development for staff so that they can update their skills and learn the procedure, providing support when there are family parent concerns. Upper administration needs to know and understand the disorder and the team procedure, and then attend meetings to support school-based personnel. And then lastly, last resort, providing access to legal team when there are concerns that go that far. So in order to make good, sound decisions, school administrators must know what a swallowing feeding disorder is, its risk factors, and things like that. So they also need to know why it's important to address it. So let's start with just going over what exactly is it. Well, the World Health Organization just came out with a new classification, pediatric feeding disorders, and that is defined as impaired oral intake that is not age appropriate. And it's associated with medical, which of course would be the dysphagia piece, nutritional, feeding skills, and our psychosocial dysfunction. So it covers a very broad range. So in a more slightly detailed, specific definition, a feeding disorder are delays in disorders in the development of eating and drinking skills that can affect weight and nutrition. It's whenever a child needs special equipment. If they need a special bowl or a cup or utensils or positioning, then they have a feeding disorder. When they have behaviors or sensory concerns such as food aversion and feeding jags that result in a limitation of the foods that they eat. And when a student needs someone to assist them with eating at school. So if they need someone sitting with them one-on-one or two-on-one during meal times or giving them directives, then that is considered a feeding disorder. The risk for feeding disorders is undernutrition, dehydration, frequent absences, and inefficient meal times. Dysphagia is a medical term for swallowing. So swallowing and dysphagia are synonymous terms. And it's broken down into three, sometimes referred to as four phases. The oral phase is the oral preparatory and the oral transit. And that's when we just get the food in our mouth, we manipulate it through chewing and saliva, and it forms into a bolus. And once it's ready, then it enters the oral transit phase where it is propelled backwards and it exits the oral canal and goes into the pharynx. So what are the risk factors associated with the oral phase, which, by the way, is probably the most common phase that we address in the schools. I would say we followed 200 students in my school district with swallowing and feeding, and the majority of them were oral phase. Choking risk is number one. Because their oral mechanism does not function as it should, they sometimes swallow food that is too big for them and will not go down and will block the airway. So they're a very big choking risk. And then undernutrition, because sometimes they work so hard to chew that by the time their lunchtime is up, they really haven't consumed many foods. That takes us into the pharyngeal phase. So during the pharyngeal phase, so the food moves down into the pharynx and the vocal folds close to keep the food in liquids. And this is a very simplistic definition of the pharyngeal phase. There are many little steps that take place and the timing has to be perfect. The larynx rises inside the neck, the epiglottis moves to cover it, providing airway protection. So the main job of the pharyngeal phase of swallowing is to protect the airway. So the risk factors associated with the pharyngeal phase is aspiration, undernutrition, dehydration, and then frequent illnesses and absences such as aspiration pneumonia. So it can be a very dangerous situation if a child is aspirating and something isn't done for it. And then what takes us to the esophageal phase. So it goes from the pharynx into the esophagus. The esophagus swallow function is characterized by an automatic peristaltic wave that carries the bolus to the stomach. The esophageal phase, we often have food refusal, disruption during meals, again, undernutrition, and frequent absences. The esophageal phase is a medical condition, and the schools, if they suspect esophageal issues, would refer to the parents to a physician. So you can look at, these are the signs of a swallowing and feeding disorder. We talked a little bit about this morning. These are things that your classroom staff will observe and that your SLPs and your OTs may observe. It's important to know what they are. And if you adopt the procedure, the first form goes through all those and they check it. So what about, are these children in your school? What is the incidence of swallowing and feeding disorder in children with disabilities? First of all, up to 90% of children with autism spectrum disorders have a feeding and swallowing disorder. Now, we tend to think of those children as having behavioral disorders, but the research is showing that there is a very high incidence of children with esophageal dysphagia, with oral phase. So these children, if they're in your schools and they're having difficulty eating and with mealtimes, need to be looked at. Up to 80% of children diagnosed with developmental delays will have some form of a feeding or swallowing disorder. 26% of our premature children have feeding and swallowing disorders. Even 25+% of typically developing children are considered picky eaters, which is a feeding disorder, or can develop into a feeding disorder. And then look at this range, 19 to 99% of children with cerebral palsy will have some form of feeding and swallowing problem. So if you have any children in your district with swallowing and with cerebral palsy, there's a very good chance they have a swallowing and feeding disorder. The rates will increase with the greater severity of cognitive impairment and decline in motor function. And then again, 50 to 80% of children with Down syndrome will also have it. And they also will really manifest it in oral phase, pharyngeal phase, esophageal phase, and behavioral feeding, all of those. So this is just a chart that you can look at on your spare time. Just to drive home, these are some of the main children we see in our schools, and look at the signs of a swallowing and feeding disorder that these children with Down or cerebral palsy or Duchenne's muscular dystrophy have. So it's real important that if you have these children in the schools, that we do something to help them eat safely at school. We're going to talk about why school districts need to address it. First of all, we know student safety. We have that legal obligation towards student safety, but we also want our children to be safe at school. So in order for them to have adequate nutrition and hydration and to access their curriculum and succeed as students, they have to have adequate nutrition and hydration. And in order to do that, many of these children need to have modifications made, not only to their diet and to their liquids, their foods, their liquids, but they need special equipment, they need special positioning. So it's a fairly complicated process that involves a lot of professionals working with these children to get them safe. We also know that the regulations of IDA and 504 require that we protect the health and safety of students. In fact, they go so far as saying that in loco parentis, when a child is at school, we are in place of the parents. We are operating as the parents for the health and safety of children at school. So it's that important. We also have IDEA regulations, and we know that with IDA, health is a related service, and that if it's necessary for a child to remain in school on a regular basis, then we must provide it. And again, back to that foreseeable harm, IDA says we have to take necessary steps for that. There's legal mandates that we must comply with. There were two Supreme Court cases. TATRO kind of separated how you tell whether it's medical or health, which of course, if it's medical, it needs a physician and it's only for evaluation purposes. But if it's health, it can be a nurse or another professional. And it's necessary for the child to stay in school, does not require a doctor. The Garrett case just agreed with TATRO and went even further at the steps we must take to keep these children in school when they have medical issues. There's also a number of state courses that set precedent. These kinds of things are important for administrators to know, that anytime an issue with swallowing and feeding comes into the courts, that the state courts have ruled in favor of school districts addressing it. And that sets precedent, which means if the district were sued, the attorneys on both sides would be looking at these cases to see what had already been ruled on. Then we have the code of ethics for our professionals. Our SLPs, OTs, physical therapists, and nurses all have within their code of ethics the importance to look out for the well-being of the children they serve. ASHA puts it the welfare of the persons they serve. AOTA says an obligation not to impose risk of harm, even if it's without malicious or harmful intent. School nurses must actively promote student health, safety, and self-worth. So it's good for administrators to know that these professionals, and PT same, these professionals are operating under a code of ethics for which it is not an option for them to not follow. They must follow it. So if an SLP or an OT sees a child that they know is struggling with their eating, they really have to do something about it. They also have an obligation in competency of the scope of practice. ASHA says that you must operate within your scope of professional practice and competence. AOTA goes even further and says, that you really need to take steps in continuing ed, research, supervision to ensure proficiency. So it's part of your job and it's part of your scope of practice. You need to do what you need to do to get the knowledge and skills. And your administrators need to know that this is an obligation that you have professionally, and it will take the help of an administrator to provide professional development and our time and continuing ed units. And then finally, USDA regulations. And these are this is the food service program. And what it says is that if you participate in the school food service program, then you must provide substitutions or modifications in meals for children who are considered disabled and whose disabilities restrict their diets. So children who are with feeding and swallowing disorders, who are IDA or 504 eligible, have the right to have their food modified for their safety.